Beautiful day out there today, although coming back to Durham and starting to sneeze and cough again was great. This is today's CME on the internet, and I'll write it down here in a sec. A lot of stuff going on this month. It's Asian American and Pacific Islander Heritage Month. It's also Stroke Awareness Month and ALS Awareness Month, two things we're very aware of down here, and thanks to everyone who's involved in these projects. Little research roundup. Cheryl was part of a new literature review summarizing the diagnosis and management of unanticipated changes in consciousness. And Sneha Mantri was a senior author on a commentary about using narrative medicine to deal with palliative care in Parkinson's disease. So great. Nada was the first author on an AHA statement recommending screening for cognitive impairment after stroke. And Wayne was part of a review article looking at transcranial direct current stimulation for stroke rehabilitation. Great work by everyone. Maria Perrone deserves special credit for setting up the Duke NCCU Neurology and Neuroscience Career Day that Andrew and Will were involved in. She really put in a huge amount of effort, and it was a huge success, and thanks to everyone who was there. This week at Duke, the Dreams MS group has a seminar today. Jamelia Minga is going to screen her 30-minute documentary on the right hemisphere and stroke on Saturday at the Rubenstein Arts Building. And Andy Liu is going to be a walk and run for tuberous sclerosis in Rock Hill, which is in South Carolina, isn't it? That's a long way off. Good for Andy. AAN this year, we'll put this together, but there was a huge contribution from people in the department to this year's AAN meeting. Janice Massey received an Excellence in Mentorship Award. Deborah Rose and Tanzia won Research Scholar Awards, and Sarah Hassani, the Transcend Scholar. We were part of 20 posters and abstracts and led 6 different sessions. So a really great meeting to everybody. And part of it was the get together that Will put together for everyone in the department at Legal Seafood. It really was a nice event. And next year, the AAN is in Denver. Again, this is today's CME code, and today's case presentation is Ahmad Zamzam, who is the Stroke Fellow this year. So I will get out of this and turn it over to you. Where's your, which one is yours?
I'll have to search it.
Oh, I just need to share it. Let me stop sharing first. Which one is it? It's like a super secret share. It's this one. Are we make sure or not? Make sure. Okay, we should be good to go.
Good morning. My name is Ahmad. I am one of the stroke fellows here at Duke, and today I will be talking about one study in particular, very briefly, about basilar artery occlusion. Those are the 2 articles I'll be talking about. The one on the left, and I'll be referencing a little bit the one on the right. The 2 recent articles in regards to treatment of basilar artery occlusion. So just quickly before I go into the study, which I'm going to talk about, a little bit about prior scientific data. So 2 studies, which those 2 articles were referencing frequently, which were the BEST and BASICS. and both of which did not show a clear benefit of thrombectomy over medical care in patients with basilar artery occlusion. Basic study, however, was recruiting within 6 hours of stroke onset. And both basics and best, they had a higher proportion of patients who received IV TPA. Basics in the end, they did a suggestion, or there was a suggestion of benefit in favor of thrombectomy in patients with a baseline NI stroke scale of at least 10. For today's study, I'm going to talk about really briefly about the trial of thrombectomy 6 to 24 hours after stroke due to basilar artery occlusion. And the study was aiming to assess the effect and safety of endovascular thrombectomy, solitary device, in conjunction with medical therapy, as compared with medical therapy alone, which was the control group, and patients with acute ischemic stroke due to basilar occlusion, artery occlusion, and an absence of a large baseline infarct on neuroimaging, who underwent randomization 6 to 24 hours after symptom onset. The study was conducted over a 5-year period in China, so they included only Han Chinese population, 18 to 80 years of age. Pre-stroke modified ranking scale was 0 to a 1. NIH stroke scale initially for recruitment was 10 or more. However, due to the slow recruitment, they decided to recruit 6M+. There was no recent ICH. And the posterior circulation aspect score, they included 6+ or more than 6. One of their recruitment or exclusion criteria was the Pons midbrain index stroke scale of less than 2 points. The higher the points, the larger the stroke. They randomly assigned patients to either the thrombectomy plus medical therapy or medical therapy alone in 1-to-1 fashion. A total of 217 patients, equally distributed 1-to-1 again, were included in the analysis. What's interesting is the randomization occurred at a median of 663 minutes after symptom onset. That was the median. And only 14 patients in the thrombectomy group and 21 patients of those in the control group received IV TPA. The original primary outcome, which was a score of modified ranking scale of 0 to 4 at 90 days, that was the original primary outcome. However, that was changed later on to 0 to 3, and the original primary outcome became a secondary outcome. Primary safety outcomes were symptomatic ICH at 24 hours and 90-day mortality. Enrollment was halted at a pre-specified interim analysis because of the superiority of thrombectomy. For the results, it was a modified ranking scale of 0 to 3, occurred in 46% in the thrombectomy group and 24% in the control group, with a p-value of less than 5%. Significant confidence interval. The symptomatic ICH occurred in 6% of the thrombectomy group, 1% of the control group, while the mortality at 90 days was 31% and 42% respectively. Non-significant. These results differed from what we spoke about a little bit earlier, basics and the best trial, and were similar to those of the Essential trial, which I'll be talking in more details about during my journal club on Thursday, May 18th. Stay tuned. Last slide is the limitations. That's it. That's it. There was no case. We decided to do this. Yeah. The limitations for the study, 3 major limitations initially was an NI stroke scale of 10. And there was uncertainty still exists regarding the benefit of thrombectomy as compared to medical therapy alone in patients with NI stroke scale of less than 10. And the cause of the underlying occlusions in those patients, knowing that they were only recruited from the Han Chinese population, was atherosclerosis, while if we would want to extrapolate that into more generalizability, such as cardioembolic, that's a limitation there. And then the amount of men enrolled in comparison to women in the trial was more men. Yeah, thank you.
So it's safe to say that those studies didn't solve anything? Yeah. Why are they in the New England Journal then? I mean, if that had been submitted to a basic science journal, that would have been tossed off to some third-rate journal because they didn't answer any question. Am I right?
Well, it's a takes a village.
All right. All right, we're going to have Wayne do the introduction here. Come on in, Wayne.
Sure. Let me just open this. Do I still do the share?
Yeah, you're going to send some slides up.
I'm going to use this background.
You just start talking, I'll put it up.
Okay. Well, good morning. Thanks for coming for the Neurology Grand Run. As Richie pointed out, May is a busy month, but as a stroke division chief, the one really I care most is the National Stroke Awareness Month. As today, sadly, stroke still the number 5 cause of death in the US. In North Carolina, it was number 5, but actually now we are number 4 cause of death. It still remains the leading cause of permanent disability in the US as well as in the worldwide. It's still a long way for us to battle this disease. Duke, we have a long history treating stroke patient. Thanks to Dr. Albert Heeman back in 1996, formed a cerebral vascular disease, and we really started systematic treat the disease. But today I have a pleasure to introduce the inaugural and a Duke Stroke annual speaker, Dr. Volker Hoemberg from Germany. Dr. Hoemberg attended medical school in University of Düsseldorf and Freiburg. I'm still trying to get a name correct, pronounce it correct. During the medical school, he actually did an elective in Boston City Hospital. So we can tell he's very senior and a neurologist. Although he was initially really interested in being a clinical neurologist, but he ended up as a neurorehabilitationist. His research focused on motor control, brain plasticity, has published over 200 publications in neurorehabilitation. He's absolutely instrumental for neurological rehabilitation in Germany, Europe, I will also say worldwide. He co-founded the German Society of Neurological Rehabilitation in 1989, and he served as the president from 1998 until 2004. He created neurological rehabilitation services in 6 hospitals in Germany. And off note, I want to point out that he was a medical director, head of neurology at a Santa Maritas Therapy Hospital for 10 years. And then he moved on to another hospital, become the medical director and head of neurology for SIH. And for 10 years, that hospital have 200 beds of rehabilitation, even have international sections, very large hospitals. He retired the position and last year. Now he take a new challenge and is the president of the World Federation of Neurorehabilitation. So today he will give us talk on neurorehabilitation after stroke, advanced, unsolved question and perspective for the future. But let me first really present him for the Duke Annual Speaker Award. Please come.
I just want to make a comment. Those are all very impressive. But do you know John Krakauer?
Oh, yes.
Yeah, that's just a little.
I haven't met him for 2 years. So.
I haven't either, actually. Okay. Let me get this going. Thank you for coming. Is it okay? Share screen. God, it's so complicated, isn't it?
Okay, to save time, first, Wayne, thank you very much for the kind introduction. It's a great pleasure and honor for me to be here, and I enjoyed a lot of hospitality here in this area. And what I will try to do within the next, 40 minutes or so, is to give you a short tour d'horizon on aspects of neurorehabilitation. I'm doing that for more than 30 years now. And I think there are a lot of advances, but there are even more mysteries and enigmas. And we are still, of course, faced with a lot of international problems in spreading the information. Okay, can you hear me well? So tell me, how can I advance this?
Click on it or use the arrows here. So forward.
This is forward.
Just click on it. No, try.
No? Oh, yeah. So this one would. Okay, so I'm currently working as, or serving as Wayne mentioned, as president of the World Federation of Neurorehabilitation. I was involved in founding this 25 years ago and was the Secretary General for many years running this organization. The aim of the World Federation of Neurorehab basically is to advance research, to advance education, and to advance services all over the world in this very field. Let's have a short glimpse at the global situation. This is data which the World Health Organization has put together in the end of 2019, 21, to be honest, and they claim that over 1 billion people in the world live with some form of disability, which is more and more increasing. Also, the COVID-19 pandemic, of course, has very much contributed to an increase in the frequency of the need for rehabilitation. And put this together, the claim of the WHO is that 1 out of 3 people today are estimated to be living with a health condition that may benefit from some form of rehabilitation. So rehabilitation is an important international healthcare issue. We were glad that the WHO, even at the height of the pandemic, changed their mind in the sense that they were going away from communicable diseases into a more general approach and looking at many aspects of neurology. There's a little bit of an awkward phrasing that they say is epilepsy and other neurological disorders, but we are happy that WHO is going into this direction, and WFNR is happy to support their intersectoral global action plan for this. Oh, you're all familiar with that. We have made over the last 20 years or so a lot of advances in acute stroke treatment, of course. We are not that good at all in primary prevention. All of you know that the control of hypertension, for instance, is still an issue, a public health issue, which is really not solved completely. We have made a lot of advantages in acute treatments with IVTPA, with mechanical thrombectomy, which really was sort of a game changer in this field. We have better services in hospitalization, and also we make advantages in secondary prevention. And at the end of it, and the very uppermost is rehabilitation, because although the quality and the strategies of acute treatment have been improved considerably, still quite a lot, 60, 70% of stroke patients will have remaining disabilities and remaining impairment of their activities and their chance for interaction with the society. Okay, in neurorehabilitation over these last 2 or 3 decades or so, we have learned, which is important, we have learned to conceive neurorehab as a form of applied neuroscience. But neurorehabilitation also goes beyond the neuroscientific approach, and a lot of other aspects have to be incorporated. Information from social science, from political aspects, and of course are important when it comes to a, let's say, global system of neurorehabilitation. This is an old slide, put that out 20 years ago. And the question is, what we can really do, what strategies we can work in patients with irreversible brain damage. This is, as you see, sort of a hierarchical organization. And of course, it would be most desirable to replace the dead tissue by healthy tissue. There are attempts to do so, but they're still very much in its infancies. More important, certainly, is to make use of the inherent properties, plastic properties of the central nervous system by waking up alternative structures, which is a restorative approach, as you can imagine. we will see we are not very much advanced in this field yet. We are much better in compensatory strategies, for instance, teaching bypass strategies or replace functions by aiding devices and so forth. Okay, this looks to be a busy slide. It's very easy to understand. It's just top down the way from impairment oriented rehabilitation to activity oriented rehabilitation, which also means to go from a restorative to a compensatory approach. And as you can see, in the faced with high amount of impairment, we don't have that much. We have gross motor activity, neuromodulation, and eventually pharmacology. We come to that. We have a critical time window after stroke, which is more or less, as most of you will know, around 3 months, maybe a little bit longer, depending on the intervention you use. And after that, you still can do rehabilitation, and we don't have critical time windows anymore at the end of that. Okay, there are a lot of enigmas still and mysteries in the field. This is work from Stephen Seiler and John Cracker from Hopkins years ago, and they made an interesting observation in animal experimentation with rodents that, of course, if you put in an experimental stroke in these creatures, their learned behavior will decline. But if you do, after some while, a second stroke, then for whatever reason, they tend to improve faster than with just one stroke, which of course is somewhat paradoxical. You see that here, this is the learning, can I use this? Yeah, this is the learning behavior before the stroke. Then you install the first stroke, of course that drops dramatically down, doesn't recover very much over training. And then you install the second stroke, goes down again. And then the slope of the learning curve is very much improved. And we do not understand that completely, what is really going on. Obviously, there is some molecular expression of certain genes or other mechanisms which may contribute to that. Okay, we have high-tech options and we have low-tech options in neurorehabilitation. Let me briefly allude to that to some extent so that you get a, let's say, framework of understanding of what is going on there and to appraise that in a critical form, which I think is important. So high-tech options. I'm always asked, you know, you make so much advantage in neurorehabilitation by using better techniques of biomedical engineering, for instance. Let me go briefly through some of these aspects, starting with robots, going over VR and AR technology, brain-computer interfaces. I will probably not allude very much to neuromodulation today for paucity of time. Robots. The question is, what does an active robot do? I remember very well about 25 years ago, when we started all this robot work, people were very enthusiastic and said, well, robots and for motor rehabilitation will change the world. Okay, the robots are probably better than therapists and so forth. So there were some naive conceptual frameworks involved. But if you really carefully look what an active robot can do, well, it can move a patient who cannot move. That's basically what a robot can do. Or it may assist a patient with reduced movement abilities, not very much more. There are, however, features of these robots which may be helpful in blending into some improvement of rehabilitation strategies. The robots have a very refined sensing of the patient's spontaneous motor activity, much more delicate than a therapist can do, for instance. They allow, which is very important, very high repetition rates. They do not tire out. They are usable in severely affected patients, and usually they are augmented by some sort of intelligent software which provides excellent knowledge of results of feedback and puts the patient into a playful environment which may help to stabilize the motivation. See that in a minute. And at the end, eventually, the robots may make life easier for therapists and increase the productivity and efficiency of what therapists do. The question is, are robots effective? I put this together 10 years ago. That was the opinion in the Handbook of Neurology. And we were critical about that. And we didn't know. There were no really face-to-face comparison, things like that. The evidence situation has improved since. And when you look over the last years on Cochrane reviews, this is 2017. People who receive electromechanical assisted gait training in combination with physio after stroke are more likely to achieve independent walking and so forth. So there was a signal, there was some information that the robots might be useful. And this is the 2020, which is the last big Cochrane review where the Merrills and other colleagues have put together. And now they say people who have received electromechanical gait training in combination with physiotherapy after stroke are more likely to achieve independent walking than not using this technology. So there is an improved set of evidence indicating that there is some usefulness. The same is true also for the upper extremity to a somewhat lesser extent than for lower extremity, but nevertheless, it's clear that robots may be helpful. And the question is, what are the robots at the end of the day really good for? Allow me a preliminary set of answers, basically 2 points. One is that they may open new therapeutic windows, especially in severely affected patients. If you have a patient who is not able to sit stably on the bedside, nevertheless, you can use a gait robot to start very early with locomotion therapy. And the robots also may augment the efficiency of training by high numbers of repetitions and also the productivity of the therapist if embedded into a clever, let's say, rehabilitation design. There's this here. However, we have to be critical which type of robots we are using in which type of patient, of course. It's a differential therapeutic approach as usual in medicine. It's nothing spectacular about that. Give you an example. This is a poor chap with a left-sided hemiplegia. And when you put the patient on a particular robotic device, an end effector device in this sense, not stabilizing the lower extremity of the trunk, then even with 2 or 3 therapists, that doesn't work, of course. If you put, however, an exoskeleton system, it's not easy because it gives stability, and you can go on with this sort of thing. Okay, so this is a colleague, Maran from Italy, who some years ago nicely put this together and said, yeah, we have to select the proper robot according to the functional ambulation category of the patient. So if you have a FAC 0 without any trunk control, you can use exoskeleton systems and so forth. And there is also a hierarchical order in which robots you can use in which patient. You can also use exoskeleton robots, if you like, or exoskeleton systems as neuroprosthetic devices. The Rewalk, some of you will be familiar with that, is a good example of this. It's an exoskeleton, a wearable exoskeleton, which can help to make a complete paraplegic patient walk. This is an example, a 25-year-old chap from Saudi Arabia. We've seen the last year, and he has a complete E10 level without any sort of motion. There's no way by conventional training to bring him back to walking. And after some training, we can use such an exercise. However, one has to be very careful with patient selection, with patient training before you use that. These are not very cheap. It's about 100,000 euros per system, roughly, maybe come a little bit cheaper. And of course, one has to be not only for economical reasons, also for clinical reasons, you have to be very careful in using that or not. Proper selection of patient, proper training of patient, all of this is important. Okay, let's switch to brain-computer interfaces. The idea of a brain-computer interface, as you know, is to pick up some sort of signal, usually EEG or other signals from the brain in order to control a peripheral device. If you have a patient with a severe, let's say, upper arm motor problem with a plegia or severe paralysis of the upper extremity, you can control wire this EEG pickup of information an exoskeleton device and can help the patient to use this arm in a proper functional way. That is one idea, to use the brain-computer interface as a prosthetic device. You can also use that in patients with all sorts of problems. The question is, however, can you go beyond that? And is the brain-computer interface also a therapeutic tool? In the way that using the brain-computer interface, you may rewire some sort of circuitry in the brain and may teach the brain to go back to some voluntary motor activity. That is also possible. So there are two avenues along which brain-computer interfaces may be used. There are some reviews available at the moment concerning the evidence situation of BCI use in stroke patients. And you see from the forest plots, comparing robots with BCI, there is a little bit of a signal, it's not that clear. It's similar with standard arm therapy. The situation is not really, if you use a BCI face-to-face to standard arm therapy, it's of course better than sham stimulation. And it's also somewhat better than pure motor imagery, which can be used. So there is a little bit more than a signal. There is some hope that in future, the brain-computer interfaces may be a helpful additional tool in the course of stroke rehabilitation. And that seems to be true both in the chronic as well as in subacute stages. We are running a project together with Shiryu Sukada, who's the Einstein Professor of Neurotechnology at the University of Berlin. And I must say that in our experience over the last 2 or 3 years, the applicability of these brain-computer interfaces has been very much advanced. It takes less than half an hour today to train a patient with a proper controlling device to handle by thinking, if you like, or by some sort of malactivity, to make an exoskeleton usable in a functional, relevant way. Okay, VR and AR technology, another technological aspect. For some other reason, for whatever reason, people like to play. I may ask you among here, who is a gamer in this audience? Well, there are quite a lot, right? The gaming industry is extremely developing, and people like to play. And the question is why? And for us, the question, of course, is if people like to play, is that a possible way to make them getting more engaged into some neurorehabilitation processes? Johan Huizinga is a Dutch cultural philosopher, and he came up with the idea that all of our civilization is originating in some sense from gaming or from playing. And Clark App was the guy who coined the phrase serious games. So games for serious reasons or for serious problems or for serious projects. And there's quite a lot of these projects in which game type technology can be used. Teaching specific skills in a flight simulator, for instance, or medical skills. Many medical schools now use this to improve let's say, teaching skills. We, of course, have an interest to look in how far the VR stuff is augmenting the repertoire in a useful way, the repertoire for therapeutic strategies in various domains of rehabilitation, cognitive, motor, and also pain control, breath control, which is becoming more and more important after the long COVID problems. And you look at the hype cycle for emerging technologies, this is 2018 data. And already in 2018, the Gartner Corporation came up with the fact that augmented reality is not anymore in this peak of inflated expectations, but really drops down to a trough of disillusionment. So it's more and more accepted. It's not just the enthusiasm in having a new technology. It's becoming more and more standard, if you want. Looking at the VR healthcare market is also very impressive. It is estimated that by 2025, the revenues originated from the use of VR technology is very much increasing, as you can see. And when you look at the light blue aspects of the bars, that is the share when it comes to rehabilitation. So that is an extremely growing market. And with such growing markets, of course, you always have to be careful. What is this really useful? Okay, so what is this useful? Consider the following fact. If you have a child and you do balance control training in a child, what you usually do, you have them walk on a beam, a wooden beam or something like this. This is the ordinary and standard way of doing it, repetitive practice. Yeah. But the children don't like to do that very often, and they bore out and not that good. They do it for 5 minutes or 10 minutes or 15 minutes max, and then they lose interest in that. And if you put a child, you can do that after the age of 8, some of these goggles on, and you give them the illusion, not walking on a wooden beam, but balancing over Niagara Falls or a skyscraper scenery or something like this, then of course the thrill is much better, and that may help to improve the motivation, aiming to make the child getting involved for longer periods of time in practicing this task. So that is one of the avenues of thinking using VR/AR technologies. And this is an example we designed 2 or 3 years ago for cognitive rehabilitation, for instance, after stroke. It's embedded in a narrative of a journey around the world. You have the goggles on, and then you're traveling to various spots in the world. And then these various spots, there are different tasks which are organized in a way to train some sort of cognitive ability that may be alertness, or it may be divided or selective attention. It looks like this. This is a selective attention task. You are on the Grand Barrier Reef, and your task is to use a photo camera and pick out a particular fish which has to be photographed. You can easily adapt the difficulty of this by manipulating the number of distractions, for instance, or the timing of the task. So there is some evidence more and more that virtual reality projects are helpful. It's not very much, but it's coming up, and it has to be observed carefully, certainly carefully in future. But this gives me a short, let's say, reason for an excursion into the overlooked role of motivation. Throughout rehabilitation, neurorehabilitation in particular, for many years, we really have ignored the role of motivation. There's very, very few work which was devoted directly into the question how we can manipulate motivation and how important is motivation in a particular context. Although we very much are aware of the fact the more a patient is doing, repetition is extremely important, especially for learning routes. So looking closer at motivation, we are dealing with sort of a motivation continuum. There's a form of motivation which is called extrinsic motivation. You can also call it motivation, that you make someone motivated by external pressures of one or the other sort. You can do that, but it's not very helpful. Much better is to come to sort of an autonomous, intrinsic motivation, changing motivation into wantivation, if you like. And there are multiple ways of doing this. And gradually, we are learning a little bit to use these rules, which have been established by experimental psychologists and not people in the field of neurology in general, but from other fields. And we borrow a little bit of this information to make advantages in our design of strategies. Okay, forget about high-tech options for a moment. We have a lot of good low-tech options. That is important considering the fact, as I mentioned in the beginning, that probably hundreds of millions of people in the world do not have any access to rehabilitation, and they certainly have no access to high-tech rehabilitation. And of course, we have to make our mind up what we can do. We have learned a lot about general rules of learning, You may be familiar with the constraint-induced movement therapy concept, which is part of that. And we have learned, and we are learning more and more, how we can improve community-based rehab strategies and caregiver support options, which is all of this is low tech. And that also includes self-training strategies. If you look at elementary rules of learning, especially motor learning, as also applies to cognitive learning, then there's some simple rules, very simple rules, which should be obeyed. One is the importance of repetition. I mentioned that already. The application of knowledge of results, and put it in a feedback-oriented loop. And of course, shaping. Shaping means to adjust the task difficulty as to what the patient is just able to do, avoiding that the task is becoming boring, and also avoiding that the patient is distressed too much because the task is too difficult to do. And some other aspect should be alluded as well. Motivation, of course, is an important one. We do not know the role of social competition in affecting the motivational structure of a patient in detail. Okay, the Oscar winner of all of these learning stuff certainly is this constraint-induced or forced use therapy. There are hundreds of papers available now showing that there is a good efficiency, and they are applicable in acute as well as chronic conditions. So it's a nice tool. It's probably the best we have when it comes to the embedding of learning into motor rehabilitation. In particular, constraint-induced therapy can also be used in cognitive domains, and it can also be used in language rehabilitation using the same concept, urging the system to go into a direction using available resources and not being deprivated by a concept as learned non-use. The question, however, is if these principles of motor learning really are drivers of brain plasticity. That's a completely different issue. Consider it a fact that you have a patient with a pelagic arm. Even if you apply the best learning strategies, it will be difficult to do that. Motor learning is possible if there is some sort of motion, and motor learning, of course, is oriented towards improving the aspects of a trajectory or of a movement. The goal orientation of the movement, or the speed of the movement, the force applied, or the torque applied in an extremity. All of this will necessarily fail if there's no movement at all. And the question is what we can do to attack severe impairments of this sort. This is a very recommendable paper by John Krakauer and friends from Hopkins, published 10 years ago. And they, for good reasons, ask the question, are we getting neurorehabilitation right? And in turn, what can be learned from animal models? And the bottom line of what they said is that current rehab treatments have an only disappointingly modest effect on impairment. They may improve function and participation, but modest, if any, effect on impairment early or late after stroke. One of the reasons for that is that irrespective of what you're doing, rehabilitation, yes, rehabilitation, no, there is an inherent tendency of the system to improve to about 70% of the maximum possible amplitude between the actual state of the patient and what can be achieved the best, 70%. That means irrespective of what you're doing, you will reach about 70%. And they call it the proportional recovery rule or proportional recovery principle. We do not understand yet the reason for that. But it's not only in motor control. There are outliers from the 70% rule, especially those who have completely rotten spinal tract. There's no way, of course, of any improvement. And it's interesting to note that the proportional recovery also applies to other domains. Neglect, for instance, as an example, or recovery of language, a very similar slope of 70 to 75%. And also in animal experimentation, some sort of proportional recovery in animal rodent models mostly can be shown that a fair percentage, 50% or so, of the experimental animals follow some sort of proportional recovery slope. And it's interesting to note that this slope can be changed in these rodents by some sort of therapy. And this is much more clear in the rodents than it is in patients. And the question is why? So what makes rodent rehab in this sense different from human rehabilitation? The most likely answer is that we do not really make the patient be working for long enough time to improve that function. So the enriched environment concept was invented about 30 years ago in animal experimentation. And the idea is if you have an animal, a rodent, for instance, a kitten or what have you, with an experimental lesion, stroke, if you put this animal in a standard cage, okay, and you compare this with putting the animal in an interesting and appealing cage, offering all sorts of toys and things to play with, then you will see both in a behavioral way as well as in a structural way, dendritic sprouting and dendritic growth, for instance, that the animals in the enriched environment, interesting cage, will do much better. And the question is, why does this not really work in humans? Okay, so the question is what we could or should do to improve impairment-oriented neurorehabilitation, probably create better real enriched environments, especially for severely affected patients with a high amount of impairment. Go a little bit away from the classical school-like agenda, 30 minutes of physiotherapy, break, 30 minutes of OT, break, and so forth, and embed what we're doing as rehabilitative tools really into the everyday life of the patient on the ward. And of course, we also need to be need improvement in the understanding the dynamics of spontaneous recovery. Let me briefly look at pharmacology. Pharmacology certainly is an option. And the question is, do we have agents to influence brain recovery, really influence brain recovery, not depression, but in brain recovery in the subacute phase after stroke? And this is 20 years ago when Grotter came up with a list of all these substances which have been tried out to, in the especially acute phase after stroke, to be neuroprotective or improving in some sense the spontaneous recovery after a stroke. And as you can see, with all of these molecules involved, calcium antagonists, glutamate antagonists, and so forth, there was always nothing. Hundreds of millions of dollars have been invested into that without any response. There were two exceptions from the rule originally in this Grotter review 20 years ago. One was cerebrolysin and the other was citicoline. Citicoline is not very effective. So we decided, and why did we go for cerebrolysin? You will see that in a minute. At the moment, there are only two classes of substances in which bigger randomized controlled trials have shown some efficacy in decreasing impairment, usually in combination with physiotherapy after stroke. The first one was by François Choulet in 2011, a French colleague from Toulouse. They used fluoxetine, which is, as you know, SSRI, in a randomized placebo-controlled trial and looked at recovery, not at the influence on depression, and on recovery after stroke. And they found a signal, even using such a crude measure as the modified ranking scale, you're familiar with that, showed, and there was a significant effect that the group with the SSRI, fluoxetine in this case, was doing better than the placebo group. So that triggered off, of course, some more activities in this respect. The second substance, and we looked at that carefully, is cerebrolysin. And some years ago, we designed several trials in using cerebrolysin in the immediate post-acute phase after stroke. And we were very much impressed by the fact that even by eyeballing, not just by doing statistical analysis, you could really observe that these patients receiving sorbolancin were doing much better than you. We use not an impairment-oriented test, but a function test, which is very complex, the action research arm test. One or the other of you will know that. And it was a very robust finding. And you look at the also at the other parameters on the forest plot here, that the majority of the parameters responded very well to the sorbolancin within the sorbolancin group. That was further corroborated. We did further studies on this and showing more or less the same effect. If you use or enroll less severely affected patients, usually the effect is lower than with severely affected patients. So that is really the target group for a cerebrolysin. Cerebrolysin is what's a weird cocktail of neurotrophic factors. So it's a multimodal type of agent. And there seems to be some promise around that. So we decided a couple of years ago within the European Academy of Neurology to design a guideline on the pharmacological support in early motor rehabilitation. And we came up with a intermediate quality, it's a recommendation for two substances. One was cerebrolysin and the other was citalopram, another SSRI, given at a high dose of 20 milligrams a day. But we rejected and recommended against clinical use for a wide variety of other substances, including amphetamines, which have occasionally be used in this respect. So there is some hope, certainly, with some substances coming up. Another important issue, of course, is to use more and more digital communication tools. If there was anything good, what we learned from the bad COVID-19 pandemic, then it was that our ease in using digital communication technology has improved dramatically. And this is, of course, a very important issue when it comes to rolling out or spreading information about neurorehabilitation on a worldwide level. I mentioned hundreds of millions of people do not have access and will probably never have access to what is classical neurorehabilitation as we do it in Europe, in North America, or in some other areas of the world and in Asia. So what can be done? And certainly one is to improve the communication of what should be done and make it easily, low threshold accessible to patients. A good example, we designed that 2 years ago is an app which is designed to improve problems of long COVID in patients, looking at planning the diaries of the day, fatigue diaries, and all of this embedded into this app. So there are many aspects. There you have tools for cognitive training, for relaxation training, pain control, and all these aspects which are of relevance when it comes to treatment of patients with long COVID problems. And this app is now available free of charge in more than 11 languages at the moment. And it's more and more widely used internationally for, especially in areas where you don't have access to a decent, let's say, long COVID clinic or something like this. Well, the metaverse may eventually offer interesting perspectives. We have a running project, and the idea is to have a complete representation of what we know as a rehabilitation hospital or rehabilitation clinic in the metaverse, with all the rooms for physios, for OTs, for speech pathologists, seeing the doctor and things like that. It looks like this. And we are very much still in the very early phase of developing this. You can do it either as an AR device, two-dimensional, or you can also have it in a three-dimensional form. And the idea is that the patient has access to a wide variety of different tools. The caregivers can have a look at this. You can teach the caregivers and so forth in using this. And you know, smartphones and tablets have a huge worldwide distribution. They certainly have a much bigger worldwide distribution than a conventional rehabilitation, such as that. Give you an example, Nigeria, 200 million people. We were involved in setting up some rehabilitation beds there. They have about 40 or 50 now. And you can imagine there will never come up to the same amount of care we have available here. So the bad news certainly is that millions of people do not have access to decent rehab strategies, and high-tech options are most often too expensive and can be applied only for the happy few. The good news, however, is that reasonable rehab is not critically dependent on technology, and knowledge about learning and coaching strategies is of high impact, and community and caregiver-based approaches can be widely used, especially when, in addition, digital communication tools can offer chances for low threshold and easily accessible spread of knowledge. So some critical questions, which are very often asked when it comes to neurorehabilitation: how much is necessary? And how far does intensity matter? This is work years ago from Gert Kwakkel's lab in the Netherlands, and they looked at a lot of studies, and you can see there is a general effect of intensity. So in the sense, the more you do, the better it is. There are individual studies, this is by McCabe years ago, and they found that additional 300 hours of upper limb therapy may give rise to an increase of 8 to 11 points on the upper limb Fugl-Meyer scale. When to start treatment, I think everyone said as early as possible, but there is data also showing this is eventually not the case. The Vector study using constraint-induced movement therapy had a paradoxical result in the sense that the high intensity CIMT starting early were worse than the others. A lot of controversy has arisen from the AVERT trial, and this was one of the biggest neurorehabilitation trial ever done. And it was a surprising result. They compared patients being treated very early, within the first 24 hours, and those being treated later. And the idea, of course, originally was that the early treated patients would do better. Unfortunately, it was the other way around. One has to be very critical with these results. Nevertheless, it was in average 7-hour difference of the start in the start of treatment between these two groups. So one has to be careful with this type of information, but there is some evidence that one should wait until the patient is stable enough, and you may eventually, with too early treatment, generate some sort of harm. So biomarkers, certainly important when you come to focalized, individualized forms of treatment. Good example is the so-called PrEP algorithm with Cassistani, Australia, published. Yeah, okay. Thanks, Wayne. I will finish soon. Right. Okay, and the idea is that a combination of certain biomarkers, this a clinical score as the SAFE score in combination with transcranial stimulation, looking at the integrity of corticospinal pathways, and eventually an additional MRI diagnosis may help in prognostication of how the patient after stroke in the immediate post-acute phase is going to develop. So there's an increasing number of biomarkers available, and that will certainly go on in the future. However, one has to keep in mind, if prognostication is really useful, what are you doing with a patient who has a bad prognosis following these biomarkers? Will you stop treatment, or will you nevertheless go on? So that has to be carefully, ethically, also carefully analyzed. Okay, there is an interesting finding there, more and more very good, high quality papers in the field of neuromodulation appearing year by year. And nevertheless, I think with all of this work, except for the fact that a lot of PhD programs are running, did we really have game changers in this field? Game changer as mRNA vaccines, something like this. We have eventually some. Botulinum toxin has changed the world of spasticity control. Constraint-induced movement therapy, I mentioned that, has improved the applicability of motor learning strategies, and multimodal drugs, as I mentioned, may be helpful in future. Evidence-based medicine is fine when it comes to decision-making based on knowledge and organized knowledge, but it may also hamper the further development of something. genetics, okay? It has a tendency to always to do more or less the same with little variations. Okay, there are future perspectives, and I think one of the important one certainly is also to have a better epistemology and to think critically about the use of evidence-based medicine, not forgetting it, but improving it and making it more focal in its application. Okay, there are challenging fields, genetics, epigenetics, which will come up more and more, probably more epigenetics than DNA-based genetics. Digital communication, I mentioned. The microbiome is still high on the list. It's coming more and more on the list as a possible influence for diseases as Parkinson's disease mentions. And of course, artificial intelligence. Who of you is in favor of using artificial intelligence? Well, I think the majority will. It's extremely good in organizing data and digesting huge amount of data. It's probably not good in inventing things, but it's good in organizing things. I'll give you an example. I asked the ChatGPT some days ago, I want to write an article on the efficiency and efficacy of neurologic rehabilitation. Can you help me with that? And then the system responded, neurologic rehabilitation can be both efficient and effective in improving the quality of life of individuals and so forth. And I thought, wonderful. Let's go the other way around. So I asked the system, could you help me in writing an article that neurorehabilitation is useless? And then the system came up within seconds with an answer and said, I cannot support the idea that neurologic rehabilitation is useless. This statement contradicts the available scientific evidence and so forth and so forth. Music in my ears, of course. And then I asked the system, where are deficits in neurorehabilitation? And it came up with an impressive list. I couldn't do it better myself. This list is absolutely okay. Limited access, specialized care, lack of individualization, inadequate funding, and so forth and so forth. So ChatGPT is very much on the line, and I'm thinking of quitting my job because they do the same as I can do, right? More or less. We will see. Okay, thank you very much for your kind attention. That's all I wanted to say. Good morning. Oh, pleasure to be here, and just alert you for 2 more forthcoming meetings. Thanks.
No, actually, not.
Okay. Okay.
Yeah. Great job. So you and Krakauer are stuffing again.
Well, it's time. Yeah.
All right, I gotta run.
Okay.
Let's get at the background. I think he was taking the